How do doctors diagnose the end of periods in someone who already doesn't get them? Welcome to today's deep dive. We are unpacking a stack of clinical guidelines, NHS protocols, and gynecological research papers to solve what is honestly just a fascinating medical puzzle.
It really is. It's the ultimate diagnostic paradox.
Right, because we are looking at a biological process that has historically been entirely defined by the end of a menstrual cycle. But today we're focusing specifically on how doctors evaluate and diagnose this transition in women who, well, who do not have a uterus.
Yeah, and it's a daily reality for millions of patients. I mean, they find themselves navigating a healthcare system that's built around a metric they simply don't possess anymore.
Okay, let's unpack this. For women who do not have a uterus, whether that is due to a surgical hysterectomy or a procedure like an endometrial ablation, that standard visible marker of menopause is completely gone.
Exactly. It's just not there.
And just to clarify for anyone unfamiliar, an endometrial ablation is a procedure that basically destroys the lining of the uterus to treat heavy bleeding. The ovaries are still there, they're still functioning, but you no longer bleed.
Right. So there is no period to track, which completely upends the traditional diagnostic criteria.
Because normally you just look at the calendar, right?
Yeah, normally a natural menopause is diagnosed retrospectively. Yeah. The strict clinical definition is 12 consecutive months of amenorrhea, which just means no periods, in a woman over the age of 45.
It's clean, it's defined.
Right, it's easy to mark on a calendar. But without a uterus, that entire metric vanishes. Doctors are forced to just totally pivot their entire diagnostic approach.
To put this in perspective, diagnosing menopause without a uterus is kind of like driving a car with a broken fuel gauge. You can't just look down at the dashboard and see that the dial is on E.
Because the dial is gone.
Right. The dial is gone. So instead of looking at the gauge, you have to look for other signs that the car is running out of gas. You have to listen to the engine sputtering or, feel the car shuddering as you press the accelerator.
That's a great analogy. If you can't look at the dial, you have to look for the systemic effects of the missing fuel, which in this case is estrogen.
Makes sense.
And this brings us to the core of the medical guidelines we reviewed today. For women over 45 who do not have a uterus, medical guidelines strictly recommend what is called a clinical diagnosis.
Meaning no lab tests?
Exactly. This means the diagnosis is based entirely on symptom presentation. You are looking at the whole vehicle, how it operates day to day, rather than running to the lab for blood tests.
The engine sputtering, so to speak, and the sources lay out what those sputters actually look like.
Yeah, they do.
We have the classic symptoms that most people already associate with the transition. There are the vasomotor symptoms, which include the infamous hot flushes and the night sweats.
Which are huge.
Yeah, the data shows those affect 70 to 80% of women. And then there are the urogenital issues like severe vaginal dryness. But reading through these papers, there were some incredibly surprising symptoms listed too.
Oh, for sure. The symptoms that frequently lead to misdiagnosis. The sources outline a cluster of lesser-known symptoms that you might never instinctively connect to menopause.
Like what?
Well, we are talking about tinnitus, a persistent ringing in the ears.
Wait, ringing in the ears?
Yeah, it affects up to 1/3 of women during this transition. Then there is burning mouth syndrome, which is a literal burning sensation on the tongue and the roof of the mouth, affecting like 18 to 33%.
Wow.
Heart palpitations impact a staggering 57% of women. And then there is profound musculoskeletal joint pain, which can affect up to 70% of patients.
I really want to pause on those because that is wild. Why would a drop in reproductive hormones make your tongue burn or your joints ache? It feels so disconnected.
I know, it highlights a massive blind spot in how we've traditionally understood female anatomy. We've thought of estrogen strictly as a reproductive hormone. But estrogen receptors are located all over the entire body.
Everywhere.
Everywhere. They are in your mucosal membranes, including your salivary glands. When estrogen drops, the composition of your saliva changes, which can irritate the nerves in your mouth, leading to that burning sensation.
Oh, wow. I had no idea.
Yeah. And estrogen also acts as a natural anti-inflammatory in your joints. So you remove the estrogen, and suddenly the underlying inflammation flares up, causing severe aches. It's a full-body systemic withdrawal.
But I have to push back here for a second. If these symptoms are so incredibly broad, joint pain, fatigue, a racing heart, ringing ears, how do doctors know it's definitely menopause?
That's the challenge.
Right, because if a woman walks into a clinic complaining of a racing heart and exhaustion, how do they know it's not just severe stress from a demanding job or general aging or a cardiovascular issue?
That is exactly the issue. Because the symptom profile overlaps so heavily with other conditions, the guidelines specifically mandate that doctors must rigorously investigate and rule out look-alike conditions. They have to clear the field of decoys.
And the sources specifically highlight the thyroid as the biggest culprit here, right?
Yes. The guidelines strongly recommend ordering a TSH test, which measures thyroid-stimulating hormone. Thyroid issues, specifically hyperthyroidism or hypothyroidism, can perfectly mimic the menopausal transition.
Because it messes with your metabolism.
Exactly. Your thyroid is essentially the metabolic engine of your body. If it goes into overdrive, you experience severe heat intolerance, profound fatigue, heart palpitations, irritability. It looks and feels exactly like a severe hot flush.
So to diagnose a decline in one hormone system, they actually have to test a completely different hormone system first.
Right. They need to prove the metabolic engine is running normally before they can blame the fuel.
That is fascinating.
Once a doctor confirms the thyroid is functioning perfectly, they look at the patient's age combined with the cluster of specific symptoms, the joint pain paired with the night sweats, and the brain fog. Then they can confidently make that clinical diagnosis of menopause, even without the menstrual marker.
Okay, but knowing that the clinical symptoms are so broad and overlap with so many other things, I think anyone listening would logically wonder, why go through all this detective work?
To avoid testing the reproductive hormones.
Yeah, why don't doctors just take a quick blood test to measure the reproductive hormones themselves and solve the mystery instantly? It seems like it would save everyone a lot of time.
It is a huge point of contention. And honestly, it's often a point of profound frustration for patients who just want a clear number on a page to validate what they're feeling.
Well, the National Institute for Health and Care Excellence, the NICE guidelines out of the UK, they have a very firm stance on this. They state a surprising fact. Doctors are actively discouraged from using routine blood tests to diagnose menopause in women over 45.
It's true.
They explicitly tell doctors not to test the hormones.
What's fascinating here is the underlying biological mechanism driving that recommendation. We tend to think of menopause as a simple linear decline, like a battery just slowly dying until it reaches zero.
Just a slow fade out.
Right, but that's not how the biology works at all. During perimenopause, the years leading up to the final shutdown, hormones don't drop in a straight line. They swing wildly and unpredictably.
So they go up and down.
Constantly. They can be completely different day to day or even hour to hour.
Taking a blood test is essentially just taking a snapshot of a moving target, then.
Let's look at the actual hormone they try to test, FSH, or follicle-stimulating hormone.
Okay.
Think of your brain as a factory manager, your ovaries as the factory floor, and FSH as the manager's megaphone.
I love this analogy.
Normally, the brain uses FSH to signal the ovaries to produce estrogen. During perimenopause, the factory floor starts breaking down. The ovaries just aren't responding.
Oh, no.
So the brain panics. It grabs the megaphone and starts screaming louder and louder, pumping out massive amounts of FSH to try and force the ovaries to work.
So a high FSH level means the brain is screaming at a failing factory?
The problem is the factory might suddenly wake up the next day, produce a burst of estrogen, and the brain stops screaming. The FSH levels plummet back to normal.
Wow. Okay.
So taking a single snapshot of FSH in a 48-year-old woman is practically useless. It might read perfectly normal on a Tuesday afternoon, even though she has been experiencing debilitating night sweats all week.
That sounds incredibly frustrating for the patient.
It is. Relying on that single test can lead to false reassurances, where a doctor says, well, you aren't in menopause yet, leaving the patient confused and untreated. Or, conversely, it causes unnecessary anxiety.
Okay, but there are exceptions. Because the sources outline very specific scenarios where doctors will use blood tests for women without a uterus. It's not a blanket ban.
No, age is the primary trigger for when testing becomes mandatory. If the patient is under 45 and experiencing these symptoms, doctors need to check for early menopause. And if the patient is under 40, they are investigating something called premature ovarian insufficiency, or POI.
And in those cases, they're looking at that same follicle-stimulating hormone, the brain's megaphone.
Yes. The specific metric they look for is a highly elevated FSH level, usually defined as being greater than 30 international units per liter.
And some guidelines are even stricter, right?
Yeah, the French CNGOF guidelines add even more specificity, looking for an FSH greater than 40 combined with a low estradiol level of less than 20 picograms per milliliter.
But wait, if the hormones fluctuate wildly, why is the test magically reliable just because the patient is under a certain age? If I can go back to an analogy here.
Go for it.
If the hormones are fluctuating like a chaotic stock market graph during a crash, and you take two photos of a chaotic stock market, you still just have two photos of chaos. How does that prove anything?
That's a fair point.
Mm.
But the key is in the methodology and how they space the testing out. The guidelines are very strict that this cannot be a single test.
Okay.
It must be at least 2 blood samples taken 4 to 6 weeks apart
To prove the trend.
to prove a permanent baseline shift. Going back to your stock market analogy, a single high FSH reading could just be a temporary spike, a bad day on the trading floor.
Right.
But if you take a reading, wait 6 full weeks, and take another reading, and they are both highly elevated above that 30 threshold, you have ruled out a temporary fluctuation.
Oh, I see.
You have confirmed that the factory isn't just taking a chaotic lunch break. The factory has permanently closed its doors. The baseline operation of the body has fundamentally changed.
That makes perfect sense. You're looking for the permanent shift in the baseline, not the daily noise of the transition.
Exactly.
Okay, so we've established how to detect this transition when the ovaries are acting like a dimmer switch, slowly and chaotically shutting down over time. But what happens when that timeline is taken out of the body's hands entirely? Let's talk about the surgical removal of the ovaries.
This introduces a completely different biological landscape, and the diagnostic process changes from being a detective hunt to managing an immediate physiological crisis.
We are talking about surgical menopause. The sources outline this specific scenario: a hysterectomy combined with a bilateral oophorectomy. And for anyone unfamiliar, an oophorectomy is the medical term for the surgical removal of the ovaries.
Yeah. Sometimes this is done to treat severe endometriosis, chronic pelvic pain, or as a proactive preventative measure against certain reproductive cancers if a patient has a high genetic risk.
Here's where it gets really interesting, especially when we go back to our analogies. Because if a natural menopause is a dimmer switch, slowly turning the lights down in a room over 5 to 10 years, giving your eyes time to adjust to the dark, a surgical menopause is like walking over to the circuit breaker and flipping the main switch overnight. Total blackout, instantly.
The physiological shock of flipping that breaker switch cannot be overstated. When a premenopausal woman undergoes this procedure, the drop in hormones is sudden, it's absolute, and it's profoundly destabilizing to the central nervous system.
Just a massive shock to the system.
Exactly. Because it is so biologically jarring, these women experience significantly more severe consequences than those going through natural menopause.
The sources are very clear about the severity here, pointing out that the vasomotor symptoms, the hot flushes and sweats, they are not just immediate, but highly intense and often debilitating.
And beyond the immediate comfort and quality of life, the long-term systemic risks just skyrocket.
Like what kind of risks?
The clinical data shows higher overall mortality rates for women who undergo early surgical menopause. There's an increased risk of coronary heart disease, a rapid acceleration of osteoporosis and bone fractures, and an increased risk of cognitive impairment.
That is terrifying.
The sudden absence of estrogen essentially accelerates the aging process of the cardiovascular and skeletal systems.
It's like aging the internal organs a decade in a single afternoon. And there was a highly specific insight in the texts about testosterone that really stood out to me. We always focus on estrogen when we talk about ovaries, but they do more than that.
Oh, absolutely. Even after a natural menopause, when the ovaries stop producing eggs and their estrogen production plummets, they do not just become inert lumps of tissue.
Right.
Postmenopausal ovaries continue to produce androgens, specifically testosterone.
So they are still actively contributing to the endocrine system for years after the period stop.
Exactly. When you surgically remove them completely, you aren't just removing the remaining estrogen, you are severing that vital source of testosterone.
And testosterone isn't just a male hormone.
Not at all. Testosterone is crucial for women. It maintains muscle mass, it supports bone density, and it heavily influences sexual function. The result of removing the ovaries is a much more profound loss of libido and sexual vitality compared to a woman who goes through a natural menopause and retains her ovaries.
Wow. Because of these severe, sudden drops across multiple crucial hormones, the clinical guidelines don't just suggest treatment, they practically mandate it. The sources strongly emphasize that women under 45 who undergo surgical menopause should be offered hormone replacement therapy, or HRT, immediately.
Yes. Ideally, they should continue that HRT until the average age of natural menopause, which is around 51.
They are essentially building a chemical bridge. They are manually providing the hormones to protect the bone and heart health until the age the patient's body would have naturally made that transition.
It mitigates the systemic shock and provides the protective benefits of those hormones for the cardiovascular and skeletal systems, allowing the body to age on its natural, intended timeline rather than an accelerated surgical one.
Now, I want to ask a critical follow-up question here because the surgical guidelines brought up a nuance that I found really surprising.
Okay, what is it?
We've talked about removing the uterus and we've talked about removing the ovaries, but what if a woman only has her uterus removed? She gets a simple hysterectomy, but her ovaries are left perfectly intact inside the pelvis. Does her biological clock stay exactly the same? Does she just glide into a natural menopause later unaffected?
You would logically think so, right?
Right.
Because the hormone producers are still there, untouched by the surgeon's scalpel.
That's what I assumed.
But the data reveals a hidden physiological risk. If we look at the Women's Health Initiative, the WHI study, which tracked thousands of women for over a decade, they found that a hysterectomy alone, even without removing the ovaries, is associated with an increased risk of developing metabolic issues like diabetes later in life.
Just from removing the uterus, how does taking out the uterus affect the metabolic system?
The answer lies in the pelvic vascular network. The blood vessels supplying the uterus and the ovaries are highly interconnected. They share a complex web of arteries.
Okay.
The uterine artery and the ovarian artery actually connect, or anastomose, to share blood flow. When a surgeon removes the uterus, they have to sever and tie off the uterine blood vessels.
Oh, I see. So you are cutting off one of the major supply routes.
Exactly. The surgical reality is that the overall blood flow to the ovaries can be significantly compromised during a standard hysterectomy. You are effectively reducing their oxygen and nutrient supply.
Wow. So they just don't have the fuel they need.
Because of that compromised blood flow, those retained ovaries can actually fail earlier than they naturally would have.
The factory is left standing, but its supply chain is cut in half.
Yeah. A woman who has just a hysterectomy might find herself entering menopause several years earlier than her genetic timeline would have dictated, simply because the ovaries took a vascular hit during the surgery.
Which brings us right back to the beginning of our deep dive. She won't have a period to warn her that this early menopause is happening.
Exactly. She just has to listen for the engine sputtering.
This is why understanding this symptom profile is deeply important for patient advocacy. You have to know what to look for when the standard markers are removed.
For sure.
So, what does this all mean? Let's connect the dots here for you. If you or someone you know doesn't have a uterus, you shouldn't sit around waiting for a blood test to validate what you are physically feeling in your mid-40s or early 50s. The NICE guidelines, the research papers, and the clinical consensus are incredibly clear.
Your symptoms are the diagnostic tool.
Exactly.
Your lived experience is the primary medical data. It is not secondary to a lab test. It replaces the lab test.
Tracking your sleep disruptions, that strange new joint pain, the heart palpitations, the temperature shifts, the ringing in your ears. That is the most powerful, scientifically backed evidence you can bring to your doctor. You don't need a broken fuel gauge to tell you the car is running differently.
If we connect this to the bigger picture, it really highlights how our understanding of female anatomy is evolving. I'll leave you with a final thought to mull over. For decades, removing the ovaries during a routine hysterectomy was considered a harmless preventative measure against ovarian cancer.
Right, just taking them out to be safe.
Exactly. But given what we now know about the crucial postmenopausal role of the ovaries in producing androgens for libido, heart health, and bone density, are we on the verge of a medical paradigm shift regarding when it's truly safe to remove these tiny, powerful organs?
It's a profound question, and it completely reframes how we should view the life cycle of the human body. It demands a higher level of curiosity from both doctors and patients. Thank you for joining us on this deep dive. Keep questioning the dashboard, keep listening to your engine, and keep exploring. We'll see you next time.